Welcome back to EM Board Bombs.
Ooh,
It's a nice
back.
Wednesday evening, crisp Wednesday evening. Snow storm on the
Crisp.
way.
Yeah, you guys are getting 20 inches too. Is that the
Something
story?
like that. You know,
It's
everybody's
not
bought
gonna
up the
happen.
bread and milk already. It's great.
It's not gonna happen. It's
yeah.
gonna be fine.
It's gonna be fine. It's gonna be fine.
I don't believe it.
Pandemonium.
I don't believe it.
It's gonna be great. It's gonna be great. And
Hey,
of course, it's not so much the snowstorm. It's a problem. It's the boarding patients 3 days afterward. That's the
yes,
that's what follows, right?
Let's not get into some of that
Get to
drama,
that, yeah.
right?
Hey, so we got some awesome pearls to cover. EM Board Bombs here, of course, for every few minute episodes. We give you what you need to know, the people what they want. It's a blue collar podcast. Dr. Iltifat Hussein, excuse me, Dr.
Yeah.
Blake Briggs, me, myself, and I. We are going over some key pearls here, just covering some high yield, what you need to know, back and forth,
Yeah.
myths, facts, things that are going to be tested on, connecting it to real life. You know how we usually do
Yeah.
it. We usually just drop what you need to know.
Yeah, so here,
yeah.
but here's the thing, right? This is really going to be called EM Critical Hits, which is going to be this rapid drops of multiple pearls that are going to help you hit multiple topics on your boards. ITE is coming up, and this is for all those EM board review listeners. One of my residents actually came up to me and loved when on our premium podcast we released the whole pearl concept, which is basically just going through a bunch of EM rapid pearls. We give people what they want, and that's what we're going to do. We're going to give 10 pearls, and the first 5 are going to be available for everyone, for everyone's listening pleasure. The next 5 that you're going to get is going to be a continuation. That's going to be for our rapid bomb listener. So again, that's our premium podcast. So that's EM Rapid Bombs. You can access EM Rapid Bombs by going to emboardbombs.com and hitting on that question bank, or just search for EM Rapid Bombs on Spotify. Again, that we have more than like 500, 600 podcast episodes there. And that's for kind of rapid ITE board review learning. We have a lot of residencies signed up as well. If you want to get your residency on, by the way, just hit us up. Happy to talk to your program director. We've onboarded several recently. Briggs, let's just dive into it. Let's go. First topic. So I'm going to present this clinical scenario to you. You've got a patient who's breathing really fast, and you're staring at this VBG. That kind of looks weird, and labs have come back. The VBG shows a pH of 7.45. Bicarb is 12. Patient is tachypnic but awake. So again, their bicarb is showing 12, but their VBG is showing this like pH of 7.45, and the pH is normal, right? What's going on?
Yeah, so the big thing here is just this classic overdose that's going to be salicylate, and it's
the signature.
It's so signature for salicylate. There's really only one tox overdose that's going to cause something like this, and it's a dual hit toxin, meaning that early on, salicylates, they cause direct stimulation of the brain medullary respiratory center, and that causes respiratory alkalosis. Later on, it causes some uncoupling of pathways, and it builds up in the blood. You don't have to know any of this stuff. Just know that it causes metabolic acidosis. And so the big thing is the normal pH is a major trap. You look at the normal pH, you then see the patient's tachypnic, and then you think, oh my gosh, I got to intubate this patient. Look at them. I listen to the lungs, they're clear. They're actually compensating really well in this case. So your role is going to be what? It's the antidote is bicarb, just being pushing bicarb, and then a bicarb infusion. And so if you take that away from them, meaning that you were intubating them, you will kill this patient. This is a perfect example of what we call clean kill in emergency medicine, which means you intubate the patient, you're going to kill them. Sedation drops minute ventilation. The vent can't keep up with this patient's respiratory alkalosis. CO2 rises. pH falls further. The salicylic acid shifts into the CNS space, and it causes rapid deterioration. Bad stuff. So don't intubate unless absolutely necessary, like if they're not breathing, sure, whatever.
Right.
But keep them breathing as fast as possible. And the key here is sodium bicarb infusion, alkalize the urine, and then dialysis. Such a big thing here, getting dialysis ready early on.
Yeah. They love
a lot of these patients. Yeah, a lot of these patients need dialysis. If the levels are greater than 100, and there's some other thresholds too, you don't have to memorize. Just know that in general, critically ill patients reaching out for dialysis early. And if your facility doesn't have that, you're transferring them. Should be transferring them anyway in that case, but
right. But you got to do that early, because just getting someone started on dialysis who hasn't been on it is not an easy thing, right? And finding a facility to do that is not easy either.
Exactly.
So
especially
oftentimes,
in a snowstorm.
Yeah, they'll want to push you. Yeah, exactly. So oftentimes they're going to want to push you towards getting nephrology involved right away, especially when you make that initial diagnosis.
If you have nephrology at your hospital. Yes. So moving on. Next one. Hey, so everyone's favorite drug, Detoxin.
Yeah, hey, it's one of the
pretty
oldest
awful.
drugs that have been around forever. Hey, I mean, look, I don't agree with you. I don't think it's as awful as you think it is.
Okay.
You know, we can banter on that at some later point, but these are rapid things that we're trying to knock out. So that's a topic for another day. So acute digoxin toxicity. Let's talk about the EKG findings. No, we're not going to. We're just not going. There's so many here. Yeah, there's so many. Obviously, for chronic toxicity, that's kind of different. The scooped ST waves, all the stuff. We're not going to get into that. But we're not going to also get into the bradycardia, the VT, the AV blocks, all that other stuff that it causes. One of the most important things to understand, though, with DIG and the way they like to test it is going to be actually potassium. So potassium is something they love testing on with DIG because remember, it's going to hit your sodium potassium ATPase pump. That pump's going to fail. So when that pump fails, all that potassium is just going to linger around extracellularly. So again, that hyperkalemia, it is a prognostic factor for how bad that DIG toxicity is. A lot of times people think, oh, it's the DIG level that I need to go based off of, right? Don't focus as much on that as much as the potassium. What they're going to do is they're going to show a patient that has abnormal EKG. They're going to show that potassium that's really elevated. And that is going to be your decision point to give what? Done. Did you fab? Did you bind?
Yeah.
That's when you're giving the antidote. That's where they want to push you towards. And oftentimes the boards are going to kind of trap you with like, oh my gosh, like this hyperkalemia, give this patient calcium and insulin, things like that. So the board answer is actually going to be give them DigiFab, right?
Yes.
In real life, sure, give them calcium, give them all that stuff in real life, right? But the boards want you to focus on giving DigiFab. And the whole like stone hard thing with hyperkalemia and DIG toxicity, that's not like a thing. Don't worry about that. So just understand your potassium is going to be your biggest prognostic factor for how bad that DIG toxicity is. They are going to really have that elevated when they want you to push that digibind.
Right. I see this going with three different questions here. One, they can give you an EKG prompt. It's going to look crazy. It's that biventricular tachycardia. That's classic for DIG. You're going to look at it, and any normal person would say, hey, that's probably hyperkalemia. Let me give all the things for hyperkalemia, the insulin, the calcium gluconate, and the dextrose. And that's all correct. But then the step further is I also need to give Digibind. That's patients on digoxin. The second question they could give you is, hey, what's the number one biggest mortality predictor for a patient on digoxin that's coming in with a potential overdose? And it's hyperkalemia. Hyperkalemia, big time. The higher the potassium level is, the worse outcome they have. It directly correlates. Those are really the kind of the two main ways they could ask that, I think. Let's move on. Hey, let me set the setting for you here.
Yeah, give me the setting. Give me the patient scenario.
It's 3 days from now. Snowstorm hits.
Got it.
A family comes in. It's that they'll check all four check in at once. You know how that is.
No. It's not. Let's get this right. It's not all four that check in at once.
It's all six.
It's two that check in at once, right?
They come
you look at the red dots and you think you're going to be the nice partner.
Yeah.
You're going to be the great, team person. You're going to be like,
I'll take the hit, guys.
Knock out too. I'll take the hit. You go in the room and then you see registration still in the room.
Yeah, not good.
Registering 2 to 3 more patients.
They just keep popping up on the board.
Room. And they keep popping up on the board.
Yeah.
So you're not going to go back to your partners and be like, no, you know what? Can somebody else get these two? No, you're going to just see everyone.
You're hosed.
And next thing you know, you already picked up like a couple others, and now you're at like 8 patients an hour.
Yeah. Now you're copying and pasting like 5 notes.
Exactly, trying to get the ages right, not remembering like half of it.
Yeah, they all have like one complaint different than the other.
One subtle thing, We've all been there.
Yeah, exactly.
We've all been there.
And it's going to be Zofran prescriptions for everyone, right? JK. So family comes in, it's winter, it's cold outside, they have some non-specific symptoms. Nurse goes in there with like 5 syringes and on a chain belt, like a chain fed. Anyway, they come in with non-specific symptoms, headache, nausea, fatigue, whatever. Maybe they're throwing up too.
Yeah.
And each of them has all their vitals done. They're all completely normal. They're not tachycardic. The vitals are normal. The blood pressure is normal. Pulse ox 100%, 99%, whatever. Easy discharge, right? Absolutely not. What is the number one
No.
thing that the boards are going to
Oh my God,
mention?
they love this.
They're going to
because
mention the dog is dead.
Right. Yeah.
It's like the
they'll be
canary in the coal mine.
yeah, the dog's dead, or just they'll make it very obvious that everyone is having a headache.
Yes.
Everyone is
And
sick.
it's winter.
Right.
They will say it's winter.
And they'll always say
January.
it's not going to be like summer. You know, it's always going to be like winter. And then sometimes they'll be helpful and they'll be like, oh, there's like a wood stove or kerosene or something, you know, like something like that.
Yeah, whatever.
Right. Exactly.
Yeah.
But it's always multiple people are sick.
Right.
And at that point, you're going to need to know, you know, they might ask something like, what lab test is going to be most diagnostic, right? They'll say
That may
it
be
like
too
that,
obvious.
right?
That might even be too obvious.
Yeah, that might be. But it is what? What is the lab test they want you to do?
Yeah, it's our carboxyhemoglobin. And the problem is with the pulse ox here, pulse ox is lying to you. It's not very smart. And the problem is pulse ox can't distinguish between oxyhemoglobin and carboxyhemoglobin. So the SpO2 will look perfect while the patients are hypoxic. Now, what we can tell you, what they're definitely never going to do anymore, is the boards are never going to mention that they have cherry red skin or whatever it is, the skin discoloration. Dead giveaway. They don't use those, bold terms anymore. It's going to be more subtle, like we just mentioned. And the problem is that carbon monoxide, of course, binds to hemoglobin with like 200% affinity, causing hypoxia. And so the big thing is here, getting a VBG, getting a co-oximetry reading. And the bright red blood coming out of the tube, if they get labs, is nothing important here. This isn't methemoglobinemia, right? It's a very different condition. And the move here is giving them 100% O2. And then you don't have to memorize these numbers, but understanding the carbon monoxide half-life drops significantly when you're doing high flow nasal cannula, non-rebreather versus just nasal cannula. And then the hyperbaric oxygen, why don't you get into that?
So when it comes to hyperbaric and carbon monoxide poisoning, there are really three main things that they love testing on. One is going to be syncope. The other one's going to be like this pregnant patient that they're going to present, and understanding that the number you're looking at for that co-ox that you're looking at is going to be 15%, and severe neurological symptoms.
Yeah.
Right. So any neurosymptoms, like this, they'll present like some sort of neurodeficit. So again, it's syncope. It's going to be pregnancy with that carboxyhemoglobin greater than 50%, and then severe neurological symptoms.
Totally. Hit me with the next one. I'm ready.
So we're going to get into this next one. And I'm going to call this this is like the toxic alcohols. I love this too, because everyone thinks, oh, could it be, could it be
always talk about it.
It's always, it always comes up, right?
Yes.
And so here's like a presentation I'll give you. It's like the osmolar gap is normal. So that means that it's not methanol or ethylene glycol, right? Are you done?
No.
Wrong answer.
Wrong. Right? It's a time-dependent answer. So early on,
the
parent alcohol, either methanol or ethylene glycol, will cause an elevated osmolar gap. But that is quickly metabolized into acids, and that decreases the osmolar gap or makes it, falsely normal. And the main thing that happens is a significantly elevated anion gap.
Sure. Done.
Now, if they present late, that osmolar gap is going to be normal, basically. They're already dying. They have horrible side effects. Methanol will make you go blind. Ethylene glycol, of course, is renal failure. And could we do over like three more questions on like the antidotes and what you give, the vitamin supplements, whatever. And we have episodes on that on board bombs you should check out. But the big thing here is understanding waiting for a high osmolar gap is a fatal delay in these patients. So if the story fits and you have an unexplained anion gap acidosis, the sooner you start fameprazole, which is the board preferred antidote, the better. Don't wait for anything
else. And they
else.
will allude to this person who's like an alcoholic. They will allude, you know what I mean? And they're like obtunded, not feeling right. So that's
usually they're unsheltered as well. It's usually some mix of exactly.
Unhoused.
Yeah, thank you. So next one, you have an elderly patient that took their spouse's glipizide. Oopsie. And glucose is now 30 in the ED.
Yeah.
So everybody's hyped up. They come in the room. You got unresponsive patient. You got respiratory therapy. That's
grandma's
getting the
like this, right?
out.
It's like this. Yeah. Grandma's like, like not moving at all, right?
Yeah.
And then they're like five nurses.
RT is pumping up the ambu bag. The nurses are getting their IO guns ready. And,
like five nurses.
Exactly. Everyone's in the room. Everyone's excited. They're like, hey,
somebody's put like a 14 in the patient. Like straight up, one of your paramedics there just like drops a 14.
And then they always yell it too. They always say 14 to the left AC. They're always very proud to say it. And then they kind of say it as kind of And the first person gets like an 18. And it's always that second person that gets the 14.
14.
And the second person that gets the 14 is like 14. They yell it kind of loud.
14, right,
and everyone's
right.
like, oh.
And
geez,
no,
okay.
they didn't say 14. They're like 14 left AC. It's always like the location, or like if they really want to drop it, they're like 14 EJ.
Anyway, so the glucose is 30. You give D50, and they wake up, and everyone leaves.
Grandma's like, "What am I doing in the ER?"
Yeah, Grandma asks for some apple juice, and then everyone rips their gloves off, throws in the trash cans,
like,
and
we're
they're
done.
gone.
They feel great,
and you can't find a single person to help like get apple juice.
Right. You're done.
You're
it's
getting
like
it yourself.
D50. The D50 went through the 14, and then everyone's like, done.
Yeah. So in this case, are we done? Absolutely not.
No.
What's going on?
Yeah. So this is one of my favorite ones because, you're given D50 and you're thinking you're actually like, oh, great. Pat on the back. I did a great job. But the D50 is actually like making things worse, right? Because that glucose that you're giving, it's triggering massive amounts of insulin to be released from the pancreas. So you're going to get this rebound hypoglycemia that's going to happen. And that's classic for glipizide, classic for this drug class of sulfonylureas. So there is an antidote that you need to give. It's more or less considered an antidote or an adjunct medicine that you need to be giving when you're giving that D50 for these, which is octreotide.
Bingo.
You don't need to know like the dosing or anything like that, but they're going to expect you to know that octreotide is what you need to give, and they're going to present that patient. Sometimes they won't mention that it's glipizide or anything like that. They'll just present a patient that's hypoglycemic that keeps having these episodes of hypoglycemia. There's no like explained reason. They'll say maybe they're like a diabetic. And oftentimes, these drugs, you're talking about renal excretion, they'll maybe show a patient with like an AKI or something like that. So it's stacking up in their system. Really what that patient needs is octreotide. And that's what it's going to do is essentially it's going to shut down that massive insulin surge that's happening from the beta cells of the pancreas.
Yeah, this is such a classic thing in pediatrics too. So in the toddler age, this is the one pill can kill category. There's several drugs that are like this. Beta blockers, calcium channel blockers are in that group, but sulfonylureas are as well. So any sulfonylurea, if a toddler ingests even just one of those pills, they have such long half-lives, those patients cannot be discharged. They need to be admitted, and they need to be observed, even if they have zero symptoms, for about 24 hours or so. So just keep that in mind. Hey, so that wraps up these 5 pearls. If you're a main podcast subscriber, thanks for listening. These were pretty awesome. We got more in the future planned, but the other 5 we're about to cover are only for our premium subscribers. So how do you sign up? You go to our website, emboardbombs.com. It's like a one-click sign up. Just go to our question bank tab. You can also just click the links below here on our podcast, wherever you're listening on Spotify or Apple or elsewhere. And if you're one of those Android people. And you can go from there. Marlene is one of those. I can make fun of him. So anyway, you go from there and you listen to our podcast and you can just one-click sign up for the EM Rapid Bombs experience, and you get much more content, board-tailored content to help you for the written exam. That's really just telling you what you need to know for the boards in real life, and that's what we're great at.
Yeah, and I think one of the most interesting things I got on feedback is folks appreciate the fact that they can finish an episode on the way to work.
Yes.
And
this is overwhelming.
I know, we don't, look, we're not like the other EM podcasts that do like hours and hours of, my gosh, I'm like,
we have a life.
People have time.
We have a life.
And we know you have a life too.
Yes.
So we just really condense it down. So it's 3 to 5 minute long episodes.
Those people
Check
are super
it out.
Nerds.
Yeah. And respect to them.
Good for them. Yeah, respect to them.
They love them. We need them.
Yes. But we're not them.
For the rest of us, they're 3 to 5 minute long episodes that you can just digest down.
Just hammer out. Yeah.
Hammer out.
Exactly.
Thanks, Briggs.
We'll see you next time.
All right. Yep. Bye.